What loves to grow in sugar? Bacteria. So you have to take all the tubing, everything down every 24 hours and start new. Okay? So even if the tea-can was not finished, if it's past the deadline, you take it all down and start new. That's with any kind of feeding.
Do you run something in peripheral or do you go through a
Central line, but you're not there, but it's central line. Okay? So main things you need to know is just the nursing things. Daily weight, I's and O's, checking blood sugar, looking for fluid overload. With another way you can check for fluid overload. Listen to their lungs. Listen to their lungs. Okay, good. So I need to mention this. So if I have GERD with reflux, what am I at risk for? Aspiration, because remember, the GERD is, remember the acid coming up. So if the acid's coming up, where can it go down into? So what are you going to do with someone who has GERD? You're going to listen to their lungs. Right? So, see the connection? But see, if that was on a test and you had a patient that had GERD and you had all these things about educating and it had listen to lungs, would you even pick that?
Nope.
That's what I'm trying to get to.
Listen to their lungs.
So if they have any reason to aspirate or have pneumonia or bronchitis, anything like that from GERD, because remember, the acid's coming up, it can go down in there, we're going to listen to lungs. That one sounds like a priority. It's airway. It's airway. Okay. So once they start eating, you can do the small, frequent, moderate to high carbohydrate, high protein, low fat meals. Bland, no spice. Avoid GI stimulants such as caffeine and foods containing or anything alcohol, sodas, tea, chocolate. So it sounds like GERD, right? Kind of the same kind of diet. All right. Hepatitis.
Yay.
Do y'all remember A, B, C, D, E?
Mm-hmm.
You need to remember it. You need to know A, B, C, D, and E. You need to know how you can get each one. So you need to know who's at risk. So somebody missed the question about hand washing with someone who has a, I think, high white blood cell count. That was a test question. Someone missed that one. Hand washing is the #1 way to prevent infection, okay? So it's the same thing, hand washing. Safe water, proper sewage disposal. There is a vaccine for this. If they are in acute stage, bed rest is good. They need to rest and give them nutrient support. B, that's the one we all got the vaccine for, right? Because you can get it how? Needle sticks. It's blood, saliva, semen, vaginal secretions, sexual transmitted. So just think of what kind of risky, you don't have to say them, but think in your brain, risky behaviors. So people who do practice risky behaviors could get hepatitis B, right? So did A have anything to do with risky behaviors? What was A? Like what you're eating, right? You wash your hands, what you eat, preparing your food. And this one is risky behaviors. Okay. So C could also be sexual content, needle sticks, sharing of needles. Okay, the cause of 1/3 of liver cancer and most common reason for liver transplant. So which A, B, C, D, or E is at risk for liver cancer?
C.
C, hepatitis C, C is cancer, right? Okay, D and E. Now, only clients with hepatitis B can even get D. So if you do not have hepatitis at all, can you get D?
No.
You have to have B. And then if you have B, you're at risk for getting D, okay? And then E is the same thing. It could be fecal oral, just like A, so hand washing. Okay? Now this one's a little different, hepatitis cirrhosis. Now this is not hep C, this is hepatitis cirrhosis, different. This is a lot of times when people get the liver hepatitis and stuff from drinking alcohol. See our guy, he's got his beer. Ascites. Y'all know what ascites is? In the belly, yeah, fluid in the belly. When y'all did assessment, did y'all learn about the abdominal wave and the ascites? So if you suspect someone has a big belly and you're wondering if it's fluid or not, you can like put your hand on this side of their belly and tap, and you'll feel the weight hit your hand. Okay? And so that's just a good, easy way to tell if it's fluid or not. If you don't feel it, then it could be just fat or something else. But if you do that, and you can feel the weight hitting your hand, it's ascites. So when you go to clinical and you have a patient with that, you should try that because it's kind of cool to feel it. You can feel it. So they'll have ascites. So if I had a big belly and I had ascites, what about my eating, my diet, would you advise me that would help me?
Fluid restriction.
Okay, you might do a fluid restriction. What else? You could. Well, let's not go there because it gets kind of complicated. What else? What about the 6 small meals a day? Because remember, if they have all that pressure, their stomach might be shrunk up. So if they eat smaller, more frequent meals, they might have more comfort, right? So you might teach them that. What position might you teach them when they get in? Semi-fowlers. The spine? Ooh. All that on their chest? Which position?
Semi-fowlers.
Semi-fowlers, right? Would you put them at high fowlers?
No.
Think of a pregnant lady. Would you put her at high fowlers? No, you put her at semi. Same with this guy. Got a bunch of fluid in his belly. You're going to teach him, foods, and you're going to have him positioned because you're watching for what? His breathing. He might have a problem breathing because he has all that pressure. It's kind of the same with the COPD guy. You're going to teach the COPD guy the same thing about eating them, okay? Because he's got the big barrel chest. Did y'all
No,
talk about that?
No.
We did an hour-long crossword to 2 days, and that was.
Well, the COPD guy's got a barrel chest, and it's the same thing. You're teaching the same thing about diet because you're trying
It's
to
ascites.
preserve his breathing. Okay? So you want him to be able to take small bites and breathe. And if he eats a bunch of food, he might not be able to breathe. And he needs to conserve his energy. So you're not going to feed him a steak that he has to chew for a long time. You're going to feed him stuff that's easy to chew so he conserves his energy.
With these patients, with the large bellies, would the
Yeah.
belly be like tight?
Yeah, usually. In fact, I had a cancer patient who had liver cancer. He had a great big old belly, so he had to keep getting, what's the procedure called when they pull the fluid out? Paracentesis?
Yes.
Paracentesis. Thoracentesis is lungs. Thora, okay, para is the belly. So I was pregnant with twins at the time I was taking care of him. And I was starting his IVs and stuff like that, and he went around to the nurse and said, I feel so sorry for Michelle. She needs to have a paracentesis really bad. And the nurse laughed. She goes, you think that she has fluid in her belly? And he was like, yeah, just like me. She's like, she's pregnant. I just thought, oh my gosh, she thought I had paracentesis. Anyway, that's how big my belly was. We were matching bellies. All right, so loss of hepatic function contributes to development of metabolic abnormalities. I don't think you need to know all those. Mainly need to know about the ascites, how to treat them. They could have, okay, think about patho. What does the liver do for your body?
Filters.
Metabolize. What else does it do?
Platelets.
Platelets. It makes platelets. So if your liver is compromised, might you have a problem with your platelets?
Mm-hmm.
If you have a problem with your platelets, what are you going to look like? Bruising. What are you going to educate the patient who has bruising?
Be careful.
Brushing teeth, remember, shaving, easy stuff, okay? So you have someone with hepatic cirrhosis. Might you teach them about bleeding precautions? There's a link. You see it? So you have to think about what is being affected. It's the liver. So anything the liver does for the body might be compromised. So they could be jaundice. Now, your liver, it can be a fatty liver. Have you heard of that before? Fatty liver, good fatty liver. All right, so if your liver is normally, healthy looking, and then as it's doing all these things or trying to filter all this alcohol or whatever it is, whatever is coming against it, it can enlarge to try to, do a better job. And the liver likes to regenerate. It likes to fix itself. So if you are celebrating Mardi Gras and you're drinking a bunch of alcohol and you're assaulting your liver, if you calm down for 6 to 8 weeks, your liver can recover. Okay? But if you go right in after, you might do your liver enzymes and they're elevated. Or if you're taking a lot of Excedrin because you have bad headaches and your liver enzymes go up, if you give it a break, it will recover. But there is a point to where it will not recover anymore, and that's when the liver starts to develop like scar tissue and things like that. So once the liver gets hard and it's scarred up, then it's not going to recover anymore. So it can only take so much. Once you're to this point, like this guy is, that he's got this cirrhosis, his liver is not going to recover, okay? But like you and I, and you got elevated enzymes, you can fix it by giving your liver a break, okay? Any questions on that? They're going to be vitamin deficient, so anytime you have an alcoholic patient, they're not going to be absorbing nutrients as well. So they're going to need, they call it a banana bag. It's just a yellow feeding that has all the nutrients in it. Because their folic acid's going to be down. I mean, all these things are going to be down on them. So they're not absorbing well. Of course, mental deterioration, okay, anemia, and platelets are down. Do you have any questions about this guy? Before we go into cholecystitis? All right, so now moving from liver to gallbladder. Basically, this is kind of what it looks like.
Yuck.
Yeah, it's yuck. It does. But basically with gallstones, it's dietary things cause it. It's painful. This one's right upper quadrant. What was right lower quadrant? So it's right upper is this. What was epigastric? PUD, we talked about it. So just kind of know some of that. It'll kind of give you an idea of what's going on. Distress may occur after eating a fatty meal. That's the same as pancreatitis too, right? Fatty meal. Obstruction, inflammation. Remember the labs. It's kind of the same. Labs are going to be elevated. Infection, fever, nausea, vomiting, colic, jaundice. So remember, you may not can tell exactly what it is, but they're kind of all similar. And that's when you have all differential diagnoses, and then you're going to rule things out from there. Same thing here. If the person has an acute episode, they're going to be NPO. Now, they want these people to stay away from dairy and hot because it's high fat items. So let's take this. So which of the following may have triggered the attack?
Ice cream. Brownie with nuts. Cheese sauce. Potatoes.
think you got it, because there's only 2 on there and it's okay, right? Which one?
Cristal and
Who's the
turkey.
high fat? That's what you're looking for. Says here, if you've ever had the pleasure of working with a GI doctor, you best believe you better know if the doctor wants the patient to be NPO. These patients are constantly on the move, having tests done. Some may require NPO not only for a reason of having the test done, but for cholecystitis. If there's a diet, call the doctor, clarify. These, but y'all, you should have the PowerPoint posted with the notes. You do? Okay, good. I put those up for you. Good. All right, so the nurse is planning to teach the client with gastroreflux disease foods that increase the lower sphincter pressure. Remember that lower sphincter, say it increases the pressure. Which one did I tell you was okay? Yeah, that's the answer, non-fat milk. Because you don't want the fatty foods, and for GERD, we definitely don't want coffee or chocolate, so it's got to be non-fat milk. So it decreases reflux, increases the pressure, so it decreases the reflux. That was just review. We knew that. All right, more oncology. So what did we say was a risk factor for esophageal cancer?
Barrett's.
Which, how did they get the Barrett's esophagus?
The GERD.
Both of those, okay. All right, so you don't really have to know endocarcinoma or squamous cell, I don't have to know that, okay? But those are just the type of cells that are there, so they're the ones that are likely for cancer. Risk factors: Barrett's esophagus, alcohol, tobacco use, hot liquids, hot foods, poor oral hygiene. I drink my coffee extra hot. I know that this is a risk factor. I know it is. But why do you think that hot coffee might be a risk factor? Yeah, because it changes the cells. That's right. Poor oral hygiene. Now, y'all, you know tobacco use. It doesn't have to be cigarettes. It can be chewing tobacco. Because, and then, chewing tobacco, y'all, I've seen so many people that did chewing tobacco that have, like, oral cancer. It is not pretty to have oral cancer. So think about what you're doing to yourself. I know I drink hot foods. I know I'm willing to accept the risk, but just think about it, okay? Know what your risks are. So ulcerated lesions, dysphagia. So if you have a mass in your throat, you're probably going to have problems swallowing because you're going to feel it most likely. If it's big enough, you'll feel it. Painful swallowing, foul breath, because remember we said, like, if you have a wound that's not clean, it's going to stink, right? So if you have like a wound in your throat, you're going to have bad breath. It's basically what it is. Hiccups. So biopsy is with them, the EGD, so that's the tube that they go in and they can look, and they can do that at bedside. They usually give some kind of, did they show y'all a video and oxygenation of the?
Nope. You're so funny.
Is it on the slide? Can you look at it yourself?
She didn't upload anything.
They do like a light lidocaine sedative where you can go in and you can do that at bedside. Surgery, chemo, radiation, palpitate, we talked about all that. So what's important is nutrial status, because if they can't swallow, then they might have to have one of the other feedings. Now, this person doesn't have the NPO problem. They just have a mass in their throat. So which feeding might be best for them? Peg tube. Why not TPN? Why not NG tube? Okay, so now we're down to peg tube and TPN. Which one's better?
You can give medication instead of.
Okay, so where I'm going with this is anytime you're doing something to a person, the answer for this one is a PEG tube. The reason is because you want the body to absorb nutrients the most natural way possible. We couldn't do that for the person who's in PO because that would make the problem worse. But for this person, they just can't get it past here. So it's better if the food goes most natural way, where the body can digest it normally, okay? So, but they're gonna need help with feeding, especially if they get radiation. Remember we talked about all that? They're gonna probably need that too for a little while. And it can come out, it can be reversible. Soft foods, if they can still swallow, but they just need thickened, that's the most preferred way, right? Because we don't wanna put a tube in their stomach. They still can get nutrition this way. So the most natural way is always the most preferred way if it can be done. Colorectal cancer, third most deaths in the United States. Risk factors. What do you think this might be? It's just, this is easy, like high fat foods, red meat. So you would want these people to eat what? Lots of fruits and vegetables, healthier type foods. Screening procedures, that's your scopes. So they may, when they first manifest, they could have bloody stools. We talked about that. That's why they send you home to do the stool samples to kind of see if there's actually blood in there. Because sometimes it's a cold bleed, you can't see it with your eye. They'll do the scope to see if it's an ulcer. They may get in there and say it's not an ulcer, it's a mass, okay? So change in bowel habits. I think we talked about this on, did we talk about the ribbon-shaped stool? So this is where it goes in. This is where the information goes. Blooded stool, tarry, bleeding. Now, what does that fancy word mean? That's the urge to go. You feel like you've got to use the bathroom all the time, but you can't. So you can imagine if there's a mass in there, it feels like stool, so you think you have to go to the bathroom, right? But you can't go because there's no stool. Symptoms of obstruction. So if you, what are the symptoms of obstruction? Pain. Okay, yes, pain. If my bowel is obstructed by a mass, a twist, or something.
You feel like you have to rub it, you can.
Huh?
You feel like you have to rub it, you can, if there's something there.
Okay, what else? If my bowel is obstructed, okay, you might have some distension. I'm eating and I'm drinking, but it's not going anywhere. I'm nausea and vomiting. So if I'm eating and drinking, and the food is going in my belly, and it's going into my colon, and my body is absorbing the nutrients for the upper part that's working, and it gets stuck, what might my vomit look like?
Fecal.
It's going to poop. Okay? So it stinks. So someone who has a bowel obstruction is throwing up nasty, stinky throw up. All right? Pain, feeling of incomplete evacuation. So treatment depends on the stage of the disease. Depends on if it's a complete obstruction, a partial obstruction, how far it is up, how far down, whatever. So early signs, remember, blood in the stool, feeling like you gotta go all the time, might be constipated, change of stool, that kind of stuff. A bowel obstruction would be, that thing's gotta be pretty bad for it to be obstructed, so that probably wouldn't be an early sign. So if they have to do surgery, you probably get one of these. And I've got this case we found. This is called a stoma. Did y'all learn about this? Y'all know about stomas? Yes. Y'all have talked about them? Yes.
Ooh, she brought some goodies.
See if we get them out of the bag. I had a little stoma in a ostomy bag. I was going to talk about where it is. All right. Here's the belly button. So depending on where the obstruction was, will be where they put the stoma, right? This is a double loop one. They can do that. Just different ones. And this is what they're supposed to look like. See, it's raised. It's beefy red. The skin around it, you're going to check that. It looks good, clean. So I could pass it around. Y'all want it? Just want to look at it. Anyway, so if this is normal, if you saw one that was pale or black, would that be normal? What would you do? Call the doctor. So what about the skin? What is this area called? What is this called? What's the medical term for this area? What is this?
Lower quadrant.
What is this area around this? What is this around here? Peristoma, right? Peristoma. So if you're looking at the peristoma, what are you looking at?
The area around the
Yeah, okay, good. So you want it to be looking like this, right? Not excoriated and all that. So if you have, and I'll just leave it here till I look at it later. If your stoma is here, if your stoma is here, what might the stool look like?
Not very fun.
Why would you say runny? Because this is the beginning of the track, right? Remember? Ascending, transcending, descending, right? So if you know the way that works, then what down here might the stool look like? Okay. So that kind of gives you an idea. So it's not normal for it to be runny down here, right? And it's definitely, you're not going to have form stool on this side, okay? Now there's one called ileotomy, and it has the ischium, the tip, the ischium in there. Now that one is usually more runny if it's past the ileum, and it the thing with that one is and all of them, you have to do meticulous skin care, okay? And whenever you clean that, how do you clean it? How do you clean this thing? Is it okay to touch it? Okay, how do you clean it? Alcohol? Rub some alcohol on it?
Soap and water.
Soap and water. You just use soap and water. You clean it with soap and water. So you get in there and it came off, the bag came off, the patient's laying in bed, there's stool all over their belly. You get your basin, you get your wash rag, you get your soap, and you start scrubbing it and you clean it all up. But the skin might be excoriated, so you would be careful just because of that. Not because you can't get soap and water on this, okay? It's just the skin is hurt, and so you wouldn't do that to your skin if you had hurt, you know? So you clean it, and you've got to make sure you get all the soap off, right? Because the soap can hurt the skin. Then whenever you are ready to put a new appliance on, you're going to put the skin barrier around there, and then you're going to, the appliances, they look like this, and you measure and you cut them with scissors till they're the right size. And you want them to be, like if your stoma is, like this, then you want that, you want to cut the piece just like this, right? Because that minimizes the stuff in the bag from getting on the skin. Can y'all see? Do you want to cut it like this? No. Because what's going to happen to all this skin? Right. Okay. So someone has an ostomy and they're complaining of it filling up with air all the time. What do you think that air is?
Gas.
Gas. What would you educate them to not eat?
Gassy food.
Gassy foods. What's gassy foods?
Broccoli.
Broccoli, like stuff like that, right? Anything that would cause gas, you would Now, if you would also tell them, don't let the bag get full. You don't want it to be completely full before you empty it because it might bust, right? So when it's like halfway, go ahead and empty it, all right? So if you walked into your patient's room and that thing came off and you saw that, you walked in and you saw that, what's your first nursing action? Assess, okay. What's your first nursing intervention?
Clean it.
Fecal off of it.
Do what?
Clean
Take
it.
the fecal off of the skin.
Okay. Put the ostomy back, put the appliance, clean it, appliance back on it, right? Would it be a medical emergency if you walked in and saw that?
No.
Okay. It's not, you just fix it, right? It's no big deal, right? Okay. So there was a girl I went to nursing school with and she had some issues. And you know, she had an ostomy and a bag the whole time through nursing school and no one ever knew. Never knew. She was young and she was pretty and she went to the beach and wore bikinis and did everything everybody else did and no one ever knew. Because she had it placed low and it was small and so she could go on with her life. So I mean, it doesn't have to be like this huge horrible thing that everybody knows and smells and that you have to be embarrassed about. But you just educate the patient on how to properly take care of it, to make sure it's not leaking, to make sure it's empty, you know, all those things. And you can live normal life, like most people with one. Okay?
She doesn't have to wear a bag on it all
She
the
did,
time?
she did, but it was a very small, I mean, of course, it wouldn't hold as much. But if she knew she was gonna be wearing different things, and she was a young girl, you know, young people, we suffered for a few, so she would, just wear a smaller bag. So.
Was it a temporary?
Hers was reversible. So when it got reversed, she let us all know she had it. I'm like, oh, I didn't know you had that. It's good enough. But I guess she didn't want to tell us because, it's the thought, might be negative for people. But here is what I was talking about. That tan piece, the circle, that's what you can cut to measure to the right size. They have different ways that you can empty them. This one looks like it actually goes to it. This probably be someone in the bed that has it. The tube goes to a bigger bag, but this is the type that people that are walking around have, and it's like those ice bags in the hospital. It just flips in, flips over, and snaps. Now, like my friend, what if you were her and you were sitting here in this class with this? What kind of nursing diagnosis do you think would be good teaching for her? What do you think she's dealing with?
Impaired body.
Body image, yeah. Do you think she had a boyfriend? Yeah. You probably did. Do you think they were intimate together?
Probably.
Is that an issue? Could be, yeah. So that's the type of stuff you need to talk about. There's no reason why she couldn't be intimate if she wanted to be. But I mean, that's big time issues. Think about your own life if you had to deal with that. So that's big for these people, is talking about the feelings and self-acceptance and have the person look at the ostomy. If that happened to you or me, I don't know if I'd be like, oh, I want to see it. And I'm like, I'm not ready to see it yet. I'm not ready. I'm not ready to see it. I know it's there. But you know what I mean? You work up to that. Here's the methods of feeding the client. Looks like we got ahead of ourselves. See, the PPN is goes directly into the stomach, and then you got the TPN that goes into the vein. You can have a G tube, a J tube. All right, liver cancer. Back to the liver. All right. So yeah, usually people don't have liver cancer. If hardly ever. Remember, I talked to you and said just because you have cancer in your liver doesn't mean it's liver cancer.
Mm-hmm.
Most times when you have liver cancer, it's from something else. It's not liver cancer, it's breast that went to the liver, or lung that went to the liver, or prostate that went to the liver, okay? It's very rarely liver cancer. But it's usually associated with hepatitis B, or C, or cirrhosis. Okay, liver mets, it's a frequent site of metastatic cancer. Pain, dull, continuous ache, right upper quadrant, or back. Weight loss with any cancer. If you have a lot of weight loss really quick, it's usually going to be, it's a big red flag for cancer. If anybody you know says, hey, I've lost like 20 pounds in 3 months, I'm not even trying, it's a red flag. Loss of strength, muscle wasting, anemia, jaundice, if the bile duct is occluded, ascites. There could be a few things. But that is deep as we go, is cancers. Questions about any of that? Meds, yeah.
I have a question.
Yes.
For the pancreatitis, you said it has to skip digestion, right? So you get the TPN. Could you do the J tube since it skips digestion?
Probably not, because it just seems like the TPN is less invasive. It's a lot more temporary. The other case we're talking about with the mass, that's not as temporary because, I mean, if you think about it, they're going to be going through radiation, you know, and the person with the pancreatitis is probably only in the hospital like 3 days, you know.
Oh, okay.
If it were like a more long-term thing, I mean, I guess they could, but, I mean, you don't need to know all that. I mean, the doctor, but it's, I don't see a lot of J-tubes either. J-tubes are treated different than, I don't know if you learned about aspirating. No, you don't aspirate J. They're treated a little different, and they're not real common.
Okay.
Okay, antacids. So antacid, it's very obvious that it decreases acid, but I wanted to make sure you know it also decreases gas. Those are the trade names. I wish y'all could just learn the brand names. So much easier, but Mylantar, Maalox, but there are the trade names. Now, you got to consider increased calcium. Because a lot of these medicines are calcium, okay? Do not take within 2 hours of other meds. You need to know that. And you don't need to know that that it interferes with those meds. I mean, just know that it can interfere with the meds. You don't need to know which meds. Okay. So you're going to take 2 hours of other meds so it doesn't interfere. All right, Carafate. Now this is has anybody ever had Carafate? Yeah, it comes in a little thing. It's like pink, and it's a liquid, so it coats. Okay. Take on an empty stomach 1 hour before meals and after bedtime. Y'all, all this 2 hours and 1 hour, you have to know all that. Okay?
We have to.
You have to. You need to. You'll be glad you did.
Stomatitis, is that like just inflammation of the stomach?
No, it's like, well, yeah, I guess it is, because it's esophagitis and stomatitis, yeah. Just inflammation of the stomach, you're right. So know the times of when you take it. Bedtime, 2 hours before meals, 1 hour, all that, you gotta know that. H2 receptor antagonists, also known as H2 blockers.
So we have to know Carafate?
What?
Do we need to know the Carafate or the soup?
The sucrose.
Okay,
Yeah, you
okay.
gotta know the generic names. Okay, this is for heartburn, sour stomach, all that. Take with meals and at bedtime 1 hour before or after antacid. retention. This one can cause, your platelets to be thrombocytopenia. So, if somebody is taking an H2 blocker and they develop bruising, that's what it's talking about requires immediate attention. That's when you would notify the doctor, okay? Because that means that it's destroyed their platelet count, basically. So if someone doesn't have platelets, they might have blood in stools, okay? It all ties together. If they've lost a lot of blood over a period of time, they could have decreased heart rate or blood pressure. It affects your vitals. Healthy person usually has a platelet count of 150 to 400,000. So the definition of thrombocytopenia is less than 150. Something I wanted to tell you, I'm trying to remember. These are the proton pump inhibitors that we kept referring to earlier. Protonic, Acefex, Prilosec. Now this one you want to watch the liver function. Okay. Now this is preventative. So this is one that you would take every day. Everybody in the hospital is on Protonix. So you might need to know that medication because every one of your patients is going to be taking Protonix. If you're in my clinical and you have to get Protonix, I'm going to say, what type of drug is that? And you're going to say, proton pump inhibitor. Okay?
You go there.
Huh?
You go there. I'm gonna
Antidiarrheal, Pepto-Bismol, Lamodal, Imodium. Now, remember we talked about opioids cause constipation? Well, like Lamodal and Lamodal is, you have to have a written prescription for it. It's a narcotic. That's why it slows down your, okay? Okay, these are used as anti-inflammatory agents to relieve inflammation and pain. You're not going to need to know all those examples. Analgesic and antipyretic effects. That's what I would know. I would not know all those examples. Okay. You could just read them for FY. Mucosal barrier fortifiers. So look, Carafate is falls under here. Carafate had a whole slide to itself, but it actually falls under here. And it causes constipation. So I would definitely, seeing that Carafate again, I would definitely know that one. You see what I'm saying? All right, now. That's our slides, but now I want to go over that worksheet. Is that loaded? And I went in and read everything and made notes for you. Looks like this. So, exam 4, you're not going to see this until September 18th. So, try not to forget. I wrote on here that the page references that listed on here are probably not correct. I did not design this, but I used it, and so just go by content. If it says page number and you can't find it, you just look for the content of what it's talking about. Now, the ones I wrote on here are correct, okay? I just highlighted the objectives. So like objective 1, this is what you need to know for one objective. Okay, I want you to go through your chapters listed and read all of the nursing action priorities. Okay? Now, if I went through and I was reading them, they're very good, they're very helpful. Now, if for some reason, if there's a couple of them that do not follow your objectives, they do not apply, but most of them do. And it's all things you need to know in the nursing action priorities. We talked about some of the assessment stuff. We talked about a lot of these. Now, these labs are not hard. Now, don't try to remember up and down, but remember what's happening, and then it'll help you know up or down. So, bilirubin, if you're having problems with your liver, is your bilirubin going to be up or down? Up. Good. So, look, your albumin will be up or down? Down, because remember the liver helps metabolize proteins, and if your liver is not working like it should, then you're going to have low albumin levels, right? So just think through these arrows. Think through them. Don't just memorize them. Amylase and lipase, that's not supposed to be elevated. Platelet count, remember we talked about that? H4 is on there. Know your PPE for all your hepatitis stuff, that's on there.
Sorry.
Just read through this, and anything I wrote on the side, take note of, and just use this as your study guide. Now, some of the stuff that you didn't need to know, I just blacked it out. I didn't want you wasting your time on that. All the farm stuff is on here too. Did y'all see that? Okay. I think with the PowerPoint, and the PowerPoints, the notes in the PowerPoint, and this, and then the stuff I wrote, I think that'll be fine. So I know you're going to have to refer back to it. You're not going to remember all this. Do you have any questions? That was a lot. We went through went fast. So I know some of y'all had questions about oxygenation. So do y'all have any more on this?
Nope.
Questions? All right.
I do, Ms. Holt.
Yes.
In the syllabus it says something about as far as sectioning, are we gonna get anywhere in that depth and going into these sections on,
You should know that from your skills.
as far as going into what lab value and stuff that we already touched over was like food electrolytes and then.
I mean, the only thing you really know that you should have basic information that you're suctioning someone, you're removing acid, and then they're looking at same thing if they're having a lot of diarrhea, they're losing acid. Any other questions about this? Do y'all want to talk a little about respiratory or?
Yes.
Let's take a 10-minute break. Think about your questions.
And you, Miss Holt, you said just to upload our notes to that GI supplement.
Yeah.
I don't know if it's her perfume or what, but my chest hurts so bad. Got GERD, girl. It's making my chest hurt right now.
If your nose are scared,
And I don't know why.
It's gotta look like 3 hours.
So I got 2 left.
It is, so I don't just like put it in my bottle. And forget to do it. And I would,
Miss Holt, when is our study guide due to be uploaded?
it's, midnight for the class.
What do you have to do? What do we have to do? Oh, the GI lecture supplemental. So why would you wait? Hey, why would you wait until then? Why don't you just do it today? You've already read all the notes. Okay, I'm just making sure I'm not missing something.
I don't know off the top of my head.
I think it's on all those videos that we recently just watched. For 3 hours of
Y'all, I feel, hey, I feel nauseous. Like, right here. Like it hurts. And I think it was the yogurt that was doing it. Maybe it's not good. I know I ain't pregnant, girl. I still have my thing. No. When I went to go have it taken out, the lady didn't have the tool. Yeah. I haven't rescheduled it yet because I was telling myself maybe that's a sign. I know. I'm gonna call today.
Or at least they'll give blood. Like,
Don't.
no, like.
I never saw it. It's probably on the age of prostate cancer.
Yep. Better than the one from yesterday. Yeah, we don't have a
Yeah, I don't understand it.
Amelia, did you see that email?
It's not, test off though.
You don't have to print it. She said she was going to look at it. I didn't print mine either. This time I forgot. Yeah. Oh my God. My little brother got his driver's license.
Okay, so we're doing.
So this is what your PowerPoint looks like. Can y'all change the design? Can you change it? Because with that, see, you go back now and you can see the font's white on white. See? Can y'all change it?
Spit some lyrics,
So
man.
you can see white. This is what you, this is your, no. But it looked like the bullets were missing, but they were white.
That didn't work out very well.
This is yours. Change the design to a dark background, because it was white, and the font was white, so it was missing. See what I mean? See, like this? There's like circles.
That's the old
There's no like that. Like this one, risk factors, see? But if you change it, it'll pop up. There it is. See?
Oh, there it goes.
Yeah, change the, go where you can say, enable editing. Enable editing, so change the design to a dark background. And then like all these words are white, so that you can't
Oh my God.
Oh, sure I do.
That's why I don't look down there, because that heifer should be having all over her Snapchat. Next time I'll be like, what?
So it's there. All right, did y'all catch that? If you go to the slideshow that's on Canvas for your oxygenation, and you change the background to a dark color background, all your bullets will appear. Because what happened is the words were in white, and when the background got changed to white, the words are still in white, so you couldn't see them. that'll be the first thing we need to do. Do y'all follow me? Okay. Because, like, the risk factors, bless you, I was looking, and the risk factors were just circles. There was no words, but now, see. So, what do we need to talk about?
Everything.
Just like give us the rundown.
I have a quick question. then.
Yeah.
When we were doing our EAQs, the first quiz was a lot about, like how many liters you should give for a certain mask, and does that?
There's a chart in your book, okay? And you need to know, forgot the exact verbiage, but there's one that's like a high dose oxygen and one that's like a low dose oxygen. Level 2 should know all the low dose oxygen ones. But it's probably not gonna be on your test, but you will have to know it for your skills. But there's a chart in there, it tells you all that. But remember, just the low, it's low flow, not the high flow. The high flow is for like level 3. Okay? There's the barrel chest. What, I can't see what I'm seeing.
I've been wondering why you're talking about risk factors.
I know. I was like, well, maybe that's what she's talking about, assessment.
So y'all can't, you're not seeing what
Yeah, that's what I'm saying.
What is wrong? It's not talking. Stuck.
I have to go to slideshow for mine.
I'm not even on that screen at all. I'm not even in Canvas at all, and it's stuck up there. Alright, I'm having technical difficulty, so, y'all ask me questions. What do you have questions about?
Everything.
What do y'all know about COPD?
Nothing.
A small frequent meals, good. What else? What's wrong with them? Why do they have a barrel chest? What?
They're using their accessory muscles so much.
No, that's not why. It's air trapping. Yeah, who said that? I'm sorry. What is your name?
Tiffany.
Tiffany. I'm sorry, I didn't hear you. You're right. I'm trying to do this, and it's hard. I'm kind of. I'll just pull mine from my. Oh, you had this from last year?
Isn't it that COPD is a combination of both emphysema
It
and
is.
bronchitis? So
It is. So,
you have both the elasticity issue and the narrowing of the.
well, it's mainly the air trapping. What's happening is the body's holding on to CO2. Okay? So, CO2 is very acidic. So these people are in respiratory acidosis. And you have to teach them things to get that acid out. So how you do that is by teaching first lift breathing. Did y'all talk about that?
Nope.
Do you know how to teach that?
No.
So, remember when we were talking about the incentive spirometer and I told you that you breathe in through your nose and then you're like blowing a kiss? I have a copy of that. That's first lift breathing. So that facilitates exhaling longer than you're inhaling, and that will help get some of that carbon dioxide out of the lungs. Okay? So first lift breathing. So that's real big on teaching COPD patients. So you want them to come in and just go. Now you see how much longer I exhale than I inhale? Because that's what it's doing. Okay? You're going to teach that. They're probably going to be tripoding. You know what that is? Okay, so probably going to be tripoding. And if he's walking and he gets short of breath, he's probably going to end up doing something like this on the wall. Like kind of tripoding on the wall. Okay, and that's what they're doing. And remember the incentive spirometer. Do you inhale or exhale?
Blow.
You inhale. Yeah, I had to figure out how to say that. You inhale or exhale? You inhale. Think about it this way. Incentive spirometer. In. It goes in. Inhale. Okay. Y'all know this? Do you know what crackles means? What if you hear crackles? Yeah, because it's fluid. What if it wheezes? Then what's wrong? It's constriction, right? Asthma is constriction, right? So what if it's a bronchi? What does that sound like? It sounds like when you're drinking your milkshake and you get to the very last bit of it. That's what it sounds like. And you only hear bronchi in the bronchi. Bronchi in the bronchi. You don't hear it here. You hear it here. Okay. There it goes. See, the wheezing is the restrictive. The asthma, COPD, other causes carry obstruction. Crackles and wails is like fluids. It's all those things. Pneumonia, all that. Is CHF, that's fluid problem. And remember, anytime you have a fluid problem, you're assessing lungs. So with other content, when we talked about fluid, ascites, you're listening to lungs, right? When you're worried about fluid, you're always listening to lungs. So, what's the difference between an ABG and a pulse ox?
Pulse
Which
ox
one's
is
more
tissue.
accurate? ABGs. Which one do you need a doctor's order for?
ABGs.
Right. So, what can the nurse do immediately?
Pulse ox.
Okay. But it's not as accurate. What vital signs? What affects the reading of a pulse ox? Good. That's good.
Tapping a pulse.
Huh? Good.
Mike, so the difference between hypoxia and hypoxemia, is it the tissue or the blood?
I don't even think you need to know that.
That's what the other professor said.
Okay. Well, just look it up then.
Instead of 5 times the class.
All right, so this is somebody doing the ABG. Can the nurse do it?
No.
Where's it going? Artery. What kind of test do you do before you stick it? How do you check the circulation before you stick it?
Pulse.
Allen test. Yeah. Allen test? You do an Allen test, it's basically somehow you obstruct the vein and you have them make a fist, and then you see if the other side will give blood to their hand, because if there's a problem, you won't, if they don't pass the Allen test, you won't stick them in that one for the ABG, and then you'll do the Allen test and try to do the other one. There should be a video embedded in here of that. Thoracentesis, remember, in the lungs. Paracentesis was the belly. Is this a sterile procedure?
I hope so.
Is it going into a sterile space?
Mm-hmm.
What about the paracentesis?
No.
So what is room air? How much percent is room air?
21%.
Okay, 21. So
We
when
did
you're
learn
doing
that.
that chart, when you're doing that chart with the mass, with the oxygen concentration, talk to nurse.
Page 532.
When you're doing the chart, you just add 30. Huh?
Page 532.
Okay, look at page 532. Who's got it right? Oh, I got it. 532. So here's how you learn this. too. So, so you see how it says 1 to 6 liters is 24 to 40, depending on where it is. So that means 1 liter is 24%. So think about it. We are all breathing 21%. Okay? As soon as you put on 1 liter of oxygen, you're just adding 3. Okay? So room air is 21%. That's what we are breathing. Okay? Yeah. And then I think it goes up by 3 at a time. Goes up by 4.
You have 3 to room air and 4 after.
And then 4 and 4 and 4. And so that helps you remember that. So it's not hard if you just think about it. You can break it down like that. So all of these on this chart are low flow devices. You should know all of these things. But understand that that mask, if someone has like on a simple mask, that mask, even though we say it's whatever percentage it is, that's just an estimate. It all depends on how the person's breathing. So if I'm hyperventilating, or if I'm taking shallow breaths or deep breaths, I'm not breathing the same as her. So I'm really not getting the same percent that she's getting. It's kind of an estimate, okay, a guesstimate. And that in the mask, there's carbon dioxide, because I'm breathing out in there, right? And so when I'm getting the oxygen, it's mixing in there. And so it's a different concentration depending on how you're breathing it. So if you're hyperventilating, or if you're breathing nice and slow, which one do you think is getting the most oxygen concentration? Right, because if you're hyperventilating, you're just rebreathing a lot of that carbon dioxide, right? Y'all know signs and symptoms of hypoxia, right? Humidification, y'all talk about that? There's a little blurb in your book about someone at home on humidification, like how to deal with the condensation and all that. You probably need to look that over. That video is good. Did y'all watch that in class?
Nope.
Okay, watch that at home. You are going to post it. Y'all didn't have this?
No.
I'll post it.
She had a different PowerPoint on
Yeah, it's posted
Okay.
now.
She had like an 8-slide PowerPoint.
I'll post this for you. I'll post it on both sides so everybody has the same thing. No Vaseline, did you talk about that?
Yes.
Yeah.
Y'all have that video?
We'll have the video.
Yeah, I'll go back and watch all the videos. Sense barometer, we talked about that. What is it for?
Prevent pneumonia.
Anaphylaxis, yeah. Anaphylaxis, so lung plaque. Y'all have all this?
No.
No.
This is on your objective.
She read the objectives.
Hey, y'all, shh. It's not gonna work. Let's see, sorry, I'm just kind of reading it and seeing what I need to. If you see anything, you have questions, ask.
So do we need to know the difference between those two?
Well, just think, well, you probably do, because, I mean, aspiration pneumonia is gonna happen, and these are just some of the risk factors: tooth feeding, swallowing problems, cardiac arrhythmia, brain injury, you can't swallow while you have a seizure, you could have aspiration pneumonia. You don't have to watch the pneumonia video, it's kind of detailed, but it's interesting. You need to know cough with irreversible. Asthma is reversible, COPD is not. They need to get their vaccines for sure. There's the barrel chest.
Is it only reversible because of the medication?
Yeah, see at the bottom where it says airway remodeling, that's what I was just looking at. If you have asthma and it's bad to have exacerbations, and you want to keep those to a minimum, because every time you have an exacerbation, you have remodeling of your lungs, okay? And eventually, if you keep having all these, like if you're taking the wrong medication, if you should be on like Pulmicort, which is like a maintenance med, and you don't use that, and all you're using is your rescue inhaler, and then you're using it all the time, you're eventually going to have irreversible changes. So you need to take your medication as prescribed, and then it can be reversible. Kind of like the liver, how it can fix itself until beyond a point. That's kind of how it is here. So you want to prevent them from needing to use their rescue inhaler, which is that SABA. You want to prevent that. So that's the name of the game, is to try to get them not to need that. And if they're needing it all the time, their medications need to be adjusted. Don't want that, medical emergency. And that's the treatment. Peak flow meter. We talked about a lot of lung cancer already. Shall I talk about this? Steroids? We need to talk about this. All right, so we just talked about prednisone. Remember my lecture? So it's the same in every lecture. When you get steroids, it's all the same. And you're going to be tested on it. Probably on every test, you're probably going to have a test on steroids. So might as well just learn it. You need to know this whole slide, okay? Not so much the names of the drugs, but you need to know it reduces inflammation. That's what we talked about. Short term, it's for short term. Okay, if you have it on long term, y'all talk about the Cushing's and all that.
No.
In your, maybe you haven't had that class yet, but if you take it long term, you're going to have problems. Okay, so it's usually for short term. You can get PO, IV, inhale it, or nasal. If you're inhaling anything with an inhaler, you need to teach the patient to wash their mouth out. They don't need to have that coating. So any inhaler, you're teaching, wash your mouth out. Okay? Side effects: fluid retention, hypertension, mood swings, weight gain, gastritis, hyperglycemia, insomnia. We talked about sleep. We talked about blood sugar. It could increase your blood pressure, can make you retain fluid, mood swings, weight gain, gastritis. You don't need to know those, okay? Specifically for this content, the stuff in yellow, but all of it, because you're going to be, every single test, you're going to have one of these questions throughout the program, okay? So this is what you teach: reduce sodium intake, make patient and family aware of potential. Okay, she may be acting kind of crazy. It's some drugs I gave her. Don't divorce her yet, okay? She's labile. She's up and down in her mood swings, okay? Daily weight gain in the morning, or daily weight in the morning. So anytime you're ever watching fluid, ever, CHF, ascites, steroids, you're always doing daily weights every day. Same scale, same amount of clothing, daily weights. What are you watching for? How many pounds? What did it
Or
work?
3 times a week.
Is that what they're 1 to 2 daily? Is that what it says?
Two.
That's a good cautious.
Two
I
daily.
should say 3. That's good. 3 in a day. Monitor blood pressure and sugar. Rinse mouth after use and taper. You can't just stop these. If you do, it's going to hurt your adrenal gland. Have to taper these off. That's why if you ever got a steroid dose pack, you take a bunch of pills and then you can wean off. And remember, they taste real bitter. You wean off, you don't just stop, okay? Because then your adrenal gland will freak out and have a problem. Okay? So you need to know this drug for sure. You need to know Theodore, okay? What you need to know about this is basically the stuff in yellow. Bronchodilates, a preventative medicine. It's not for an attack, it prevents. It's got dose-related toxicity, and you gotta use blood, you gotta monitor your blood. Okay, blood levels. It's an old drug. A lot of new doctors don't prescribe it because you have to have blood testing. What other drug do you have to have blood testing? The Digoxin. What else?
Coumadin?
Warfarin?
Or Warfarin?
This one's asthma prophylactic agent, exercise-induced asthma. So if you've got a player who's going to go play some ball and he knows this is preventative before exercise, okay? Not to be used for acute episodes. It's not a rescue inhaler. We already studied anticollagen. Here they are again. Single layer, PO. It's not for acute. So that means it's preventative, right? Beta 2, remember beta 2 is for lungs, beta 1 is for heart. 2 lungs, 1 heart. Now, anytime you give this, you're going to have tachycardia and tremors. Now, this is your albuterol. My daughter had, what is that? What is that respiratory thing you don't want your kid to get? RSV. She had RSV. So she was on albuterol inhalers, and I was at work. And my husband was at home with my daughter, and she was a baby. She was probably 8 months old or something. And I got home from work, and she was sitting in her high chair doing this. And I was like, what is wrong with her? And he's like, I don't know. And I'm like, well, what's been going on? Did you give her medicine? He's like, yeah. And I'm like, well, how often have you been giving it? And he was supposed to give it like every 6. He was giving it like every 2. He said, I thought more was better. And I'm like, it is not better. I had to call poison control. I was so worried. Because she was just like, her heart rate was going. And I called poison control, and they said, just to watch her, it was fine. But anyway, so tachycardia, tremors, with albuterol, okay? So it makes you feel like it's for acute attacks, okay? It's quick. It also says it's preventative treatment for exercise induced. Remember, it's a beta 2. It's for the lungs. It's SABA. It's short acting. That's what SABA means. Short acting beta adrenergic. It's short. There is a LABA2, a long acting. This is the short one, okay? Long acting is usually more preventative. Short is usually for acute, okay? Respiratory, small frequent meals that we talked about that. Risk factors, okay. Cigarette smoking is the most significant risk factor in COPD, okay? So, what is the number one thing you can do to help your COPD?
Tell them not to smoke.
That's the number one thing, okay? Now, it's not going to reverse anything, but it's going to stop more progression. So that's the number one thing. And I'll post this too.